Good afternoon. Welcome. This is Judy Gaudet. I'd like to just take a moment for the rest of the team to be able to introduce themselves. So, Casey, if you want to start.
Yes, I'm Casey Squier, the Engagement Services Manager, as she mentioned, and I'm just excited to be here today with Vlad and Glory they're going to introduce themselves next.
Hi, good morning, everyone. This is, good afternoon. This is Vlad Rivera from Generations Family Health Center. I've been a community health worker for the agency for the last 5 years.
Glory?
Glory? Okay, I don't want to hold things up. Glory Cruz is another community health worker. And unfortunately, I'm not going to remember exactly how many years she has been with Generations, but I know it's definitely more than 4, I believe. And so, again, my name is Judy Gaudet, and as the Director of Systems of Care Department, I find myself having to explain what is systems of care quite often. And so that's the department that houses the care coordination and the value-based programs, special population grants, and the community health workers. So it's really important that we have an understanding of, what is patient-centered medical home and how can we be integrated into the care teams in order to better provide for our patients. Generations covers a 920-mile service area in northeastern Connecticut, and we serve an average of about 20,000 patients per year. And so to begin, I'm sure at some point everyone's heard it takes a village, right? And that same sentiment can be applied to understanding patient-centered medical home and team-based approach. The big question is, how do we maintain patient-centered care during a pandemic? Oh, great. My slides are not going forward. All right, technical difficulty. The slides are not moving. Hi,
Judy. Can you use a cursor key, the down cursor key?
I can't see my cursor. Let me just change my view here.
Yep, okay. It works.
Okay. So, sorry about that. The pandemic has forced us all to look at how we provide care and services and make some adjustments, right? So we had to stay focused on the 6 key components of patient-centered medical home while being really creative in how we apply them to the care delivery. So looking at team-based care, it allows us to designate roles and responsibilities. I have to get this out of there. Sorry about that. Okay. Apologies. Again, it allows us to identify roles and responsibilities within the team, and that's how we achieve whole person care that we strive for. Staff are utilized to the top of their licenses, and they're able to focus on what they do best, while the rest of the team members can support and enhance the care and services. So knowing and managing your patient, it offers us the ability to not only capture and analyze data, but it also drives our quality improvement initiatives, and it provides evidence-based data that allows us to ensure quality care that is culturally and linguistically appropriate as well. For patient-centered access and continuity, it allows us through empanelment to ensure that there's an equity in the patient volume and in the complexity for our providers. And in doing so, this promotes continuity and supports the provider-patient relationship, which really is the cornerstone for patient-centric care. And of course, we want 24-hour access for all of our patients, and we want to have that with a provider who has access to their chart after hours, so that they're giving care that is personal and appropriate to each individual. What's very, very important also, I'm sure you'll agree, is that after-hour services must be linguistically appropriate. So for us, we made sure it was part of our contract with our answering service that they must have bilingual messaging, and also that the operators have to have access to a third-party interpretation line in order to be able to communicate with our non-English speaking patients. So going back to the team-based approach, we thought it would be more important to kind of create some swim lanes, which were extremely helpful. And in this representation, you can see that each leg of the patient experience has a designated team member and job function attached to it. And all the team members are aware of their own responsibilities, which creates a smooth flow, start to finish, for the entire patient experience.
Excuse
Of
me,
course.
Judy?
Yeah?
I'm so sorry to interrupt. Would you mind just slowing it down just a little bit, please? Just
okay.
slowing down your pace a little bit. Thank you so much.
Yeah, I do tend to talk fast, so thank you.
Sure thing. Thank you.
So, at times, of course, there may need to be some cross-training. So if a team member's out or something, we can make sure that we have somebody to fill in. But for the most part, our goal would really be to utilize everyone based on their knowledge and skill set. And this is just a different version of what a care team might look like. And we show that the clinical care team conducts huddles and shares information that's related to the patient. This not only informs all the team members of what is needed for the patient visit, but it's also initiating the steps for the follow-up care and services that might be needed following the appointment. At Generations, we also conduct administrative huddles. And what this does is informs the administrative staff of provider schedules, vacant appointment slots, and where maybe to book our most complex patients. And additionally, it informs our team members where someone is out and what they need to do so as we're not disrupting the flow of the patient experience. So how do we keep patient care centered? Through care management and support, we're able to work with the patient, the family, and the caregivers to identify individual needs, determinants of health, and to effectively plan, manage, and coordinate the patient care. And oftentimes, we find that these patients are among our highest risk population, so they need a little extra hand-holding and attention to develop a care plan, perhaps identify goals, and implement interventions so that they can achieve those goals. With care coordination and transition, we find that this helps us lower costs and it improves patient safety and ensures effective communications with other providers throughout the medical neighborhood through specialty referrals, et cetera. And by tracking our tests and referrals and other care transitions, we can consistently provide care that's individualized. And so there's evidence-based and appropriate care for meeting the needs while keeping the patient at the center of what we do. And what this all leads to is the performance measurement and, of course, quality improvement. And so this establishes a culture within our organization that embraces change and strives to improve quality, efficiency, and, of course, the patient experience. We at Generations have a quality measures improvement committee, and we meet every other month. What we do is we review UDS measures, we identify areas that need work, and create performance improvement projects to meet the needs. And as a result, we have consistently, year over year, improved our quality outcomes and, of course, our quality awards. And one of the things that we do with that is assure that we are sending out monthly reports to all of our providers on where they stand in those quality measures for their patients, so we can see, where are we having the gaps in care and what do we need to focus on a little bit more. So if we think of patient-centered care as a puzzle, with the patient at the center, the care provided is team-based, it's comprehensive, coordinated, focused on quality and safety, and it's both accessible and sustainable. And in looking at that, it's also important to understand that we have to have the ability to add pieces of the puzzle, and those pieces are the spectrum of the health and community-based services and supports that we provide to the patients and their families, and they have to be very organized in a coordinated network. This way, we build meaningful partnerships to address the health, social, cultural, and linguistic needs. that will help our patients function better at home, work, school, and also within the community and throughout their life. So determinants of health, what are they? They're the health, environmental, hereditary, cultural, religious, socioeconomic, and basic needs of the patient that may increase their risk factors for illness or injury. And of course, in rural areas, the socioeconomic factors can carry a much heavier impact on our patients. In this slide, you can see that it's a good depiction of social determinants of health, and you see that only 20% of your health status can actually be attributed to the care that you receive. There's a combined 70% of risk factors are attributed to the socioeconomic factors and the health behaviors, those things such as income, transportation, housing, substance use, food insecurity, and so on. And then there's an additional 10% that is attributed to environmental things such as pollution, noise, temperatures, and so on. Drilling that down, the most predominant social determinants of health are food, housing, transportation, and financial strain. And by providing enabling services, it allows us, along with the community health workers and care coordinators, to complete the full social determinants of health assessment and be able to connect our individuals with community resources to help identify those barriers to care and hopefully give our patients a hand up in improving some of their health outcomes, but also their life in general. This very busy slide shows we have built our social determinants of health assessment right into our EHR form, and using prepare questions as well as CAGE-AID and HARC, which are the substance use and interpartner violence screenings, we were able to build this so that the staff has access to it where they can drill down granular race and ethnicity data, and they can also follow utilization costs for emergency department use and hospital admissions. By identifying a lot of these barriers, we're able to assist the patient and eliminate them and again, improve health outcomes. Additionally, components of the social determinants of health assist us to risk stratify our patient population. And again, that drives our performance improvement projects. And with this form, we have the Farmworker form, or the Farmworker community health worker form is also a component of this form. So they're able to just go in and click boxes for all the things that they do. And that makes us able to run reports on all of the work so that we're able to easily report out, but also identify again where our gaps are. So what exactly is medical home or patient-centered medical home? I think the best way it can be described is as a model of care that is patient-focused with comprehensive coordinated care that is accessible, measurable, and provides continuity. And in the end, it ensures health equity across all of our patient population. So that is a rather quick synopsis of what the 6 key components for patient-centered medical home is. And we're going to do a breakout session right now. And for each team, we would just ask that you identify for the concept that you're assigned to, how are you maybe using it in your organization? And if you are not using these concepts in your organization, what might you be able to do to incorporate them? So Sai, are you ready to do the breakouts?
Yeah, absolutely. So we have around 32 in the session right now. So how many breakouts do you want to create right now?
Why don't we just go ahead and do all 6 of them? That way it's small groups. They'll have their 10 minutes for discussion. And then when we come back, we can do, designate one person to give a quick synopsis of what you discussed. And then we can move forward with Casey Squier.
Okay, so 6 breakouts, and you want me to keep it for 10 minutes?
Yes.
Perfect. All right, just give me one moment.
Okay, apologies. I was having some technical difficulties. So if we can start with team 1, is there someone who can talk about the team-based care?
Hi, this is Maria. I work for NCFH and I was part of Team 1. I think that none of us had the health center view of it. None of us work in the health center setting that were in the group, but we did discuss, how the importance of a team-based approach when dealing, especially with chronic conditions, the necessity of involving everyone, including the family, and how sometimes, it's a little bit of a trial and error, trying to figure out which is the best approach. But there's no magic formula, but how they all try to include as many of the team member participants in decision making and all that. So that's a little bit of what we discussed. I don't know if anyone wants to add anything from the group.
Okay, so moving on, Team 2, knowing and managing the patient. Okay, how about Team 3, the patient-centered access and continuity?
Hi, this is Gia with Community Health Centers in Central Florida. So we had a brief discussion because of technical issues, but I shared that my organization, we currently have 14 centers, and we have a patient-centered medical home approach that involves from being able to provide access through the scheduling piece and working together hand in hand with a local Farmworkers associations for specific cases and specific needs for patients. We don't, in scheduling, we have access after hours because we have longer days than the normal 8 to 5 for expanded hours, as well as over the weekend. And our approach just begins with the scheduling piece, then the front desk. We have LPNs that are involved in the patient care, providing pre-visit planning, and then the provider. We also have a team of 4 case managers, which work hand in hand with the providers and the centers to be able to provide care and service to patients that are enrolled in special programs, such as chronic care management type of scenario.
Great, so that's exactly what the team-based approach is, so fantastic. Anyone from Group 4 for care management and support?
Hi, this is Brenda Hamilton. I'm with Valley View Health Centers. Our group talked a lot about the patient's needs as far as translation services and feeling comfortable with, having folks in the clinics that they can communicate with, as opposed to having to dial in, for someone to speak their language. Talking about the community health workers being the front line, and when they're out meeting and doing outreach and those things, that they really are building the relationship that will help that patient feel comfortable coming to the clinic, and then continuing that, within the clinic setting with having Spanish speaking or whatever the prevalent second language might be in the community, having those team members available that can help the patient to feel comfortable, and also just being culturally sensitive. Getting a patient into the clinic really is dependent wholly on their experience out in the field and their first interactions. And so just, making sure that the care managers are doing, their best work with connecting with the patients and helping them to, helping facilitate their experience as they come into the clinic setting and experience their care from the providers themselves.
Absolutely. And with the community health workers and the care managers that are out there, they really do become part of the community of the agricultural workers. And so having that one point of contact for them to be able to reach out to really makes a difference in how much they're going to, be able to obtain from the health center. So that's great. T number 5, care coordination and transitions.
Hi, my name is Elizabeth Gandera Castillo. I go by Ellie, and I'm not speaking for everybody in my group because we didn't all get a chance to speak up, but we were, our topic was care coordination and transitions. As I mentioned to my group, I am not part of a community health center, but part of a university agribility project. What we do is we provide resources and referrals to other agencies. And our goal is to also target some of the health centers, because I know that the migrant seasonal agriculture workers in that area, I think, are maybe falling through the cracks, and we're trying to reach them all statewide. And I'm over trying to get to the whole state. And right now it's just me right now in this position, but I'll turn it over to one of the other guys that also mentioned something on his end. If he wants to. They don't have to, but.
Hi, my name is Ivan. I work for a community health center in Central California. I was just sharing with our group how at our health center we work with different teams to make sure the patients get the resources that they need, whether we do like internal referrals to, we have medical, dental, behavioral health services. So referring them to whatever department or team they need. So whether it's they come into their provider and they want to see a counselor, or they need help with community resources, we'll schedule them with one of our resource specialists that can help them with Medi-Cal or Medicaid, I think it's what it's called in the rest of the country, but or local resources, transportation, or they come to me for like health education. And then we also have our referrals department that schedules them for any like specialists that we don't have here as part of our services. So kind of just following up with them and working with the different departments so that they can get everything here at our organization, at our site, without having to go to different appointments at different places.
So great. And as you can see, as each person's talking, each of these components blend in together. So there's a crossover from each section. And at the end of the day, it all turns into patient-centered focus. So in Team 6 for performance measurement and quality improvement, Martha was great in the discussion. She mentioned that they are not the health center, but we had a great conversation about you don't have to be a health center to be able to understand these concepts and apply them to the work that you do. So if you change the words a little bit and make it person-centered care and services as opposed to patient-centered medical home, you're able to utilize all of these approaches, team-based care and knowing and managing the individuals you're working with and putting them at the center of it. And she shared how she does that in helping some of the farm worker families get their children into the preschool and educational services and the other services that they may need. So it just goes to show that it's a very good blend of all of these components that really can be applied to everything we do in the care and services field, whether it's healthcare or not. So given that, I do want to go back and give Team 2 the opportunity once again. So that was Team 2, knowing and managing your patient. If there's somebody who is available and wants to speak on that, we'd like to go ahead and have you do that now. Okay, having no one speak up for that, I'm going to go ahead and share my screen again. Casey?
Sorry about that. Alrighty, so Judy's explains in detail the 6 concepts for PCMH, patient-centered medical home. And in the next few slides, you'll learn how to implement those concepts in how we implement those concepts in our farm worker program. Community health workers are agents for change and for patients and clients they serve. They know their population and strive to make long-lasting and meaningful but professional relationships. I like to think of the community health workers and their efforts as the glue and filler between many of the puzzle pieces that might not fit together as perfectly as we would all like. Next slide. As we all know, everything was different before COVID. Our patient engagement certainly looked different, as seen in this slide. We utilize face-to-face outreach as our main form of engagement. There are various ways to pull in new and existing clients. Sometimes it may take many interactions to form a professional relationship and trust, and at times it's a very quick process. Sharing a conversation over a cup of coffee in a break room while offering educational materials has been successful for our program. Next slide. From time to time, we play games and offer small prizes. Sorry about that. Small prizes. Hello. My goodness. Sorry. From time to time, we play games and offer small prizes to add some fun to the workday and encourage engagement. Even the supervisors get involved. Spin the wheel has become a favorite, and the questions on the wheel can be changed to cater a health topic. We may have questions on hydration, sun safety, hypertension, or diabetes, to list a few. Outreach can be conducted anywhere, in the field, in a break room, in the office, greenhouse, or even in a parking lot. Next slide. Bringing the mobile health unit to the farm has been very successful. We have a partnership with the local hospital that loans us the medical mobile health unit. We are licensed on that medical unit as an extension of our own clinic. We have an in-house Across the Smiles dental program that includes mobile dental equipment and unit as seen in the picture. We are able to care for agricultural workers, taking into consideration their needs and responsibilities on the farm. We work with the growers to coordinate our clinics during lunch breaks. Bringing the services to our patients is a win-win. Next slide. Going on the medical unit is very similar to being seen in the office. Our patients get the same quality of care. Vitals are taken, the provider does their assessment, and medications are prescribed as needed. Follow-up appointments and educational materials are also distributed. The agricultural workers do not have to miss work hours to see a provider. This is appreciated by not only the agricultural workers, but also the growers or owners. As an agency, we benefit because we get the satisfaction of knowing that we are meeting our patients' needs. We always have a full schedule and we have very limited no-shows. We offer medical and dental mobile health units, and we are looking forward to being able to offer those services again in the fields again, hopefully, who knows when, but sometime soon. Next slide. Our office has switched to mostly virtual appointments rather quickly. We had many clients that did not have access to either video capacity or internet connection. This needed to be addressed immediately. You will hear more about technology efforts in just a few more minutes. Next slide. So communication with the growers and ag workers continues to be a challenge, right? It's a challenge for everybody. It's always been our #1 challenge, and we're working on it. We have had to be creative, but with this uphill battle, it intensified a little bit during COVID when most physical outreach was halted. As a team, we became hyper-focused to communicate as effectively as possible. Next slide. We ran many lists, we ran lists of farm workers currently enrolled in our programs and reached out to identify needs. We also ran reports of past clients that may need to be re-enrolled in the program. We adjusted our community health worker lunch schedules so that we could make calls when agricultural workers were available to talk and on their either on lunch breaks or lunch times, whichever worked best for them. We also focused on growing our relationship with owners. And I think that was a little bit overdue, and we put a real big emphasis on that. This was a period of relationship building for the owners, the growers, managers, everyone on the farms. We helped keep up with ever-changing CDC guidelines. We helped with recommendations for housing issues, offered COVID testing on site or in the fields. and just did our best to grow those relationships. Next slide. Testing also had some issues, especially in the beginning. Some owners were hesitant and chose to send their clients to the facility if they presented with symptoms or had a known exposure. Fortunately, we were able to do on-site testing, and that was pretty successful. We tested about 33% of our migrant worker population. Our clinical and non-clinical staff worked together to make the process smooth and time efficient. This was noted by many of the growers. During on-site testing, we conducted education on proper hand washing, mask wearing, things like that, and social distancing too. We distributed personal protective equipment, or PPE, and hand sanitizer at these events, and also demonstrated proper PPE use. Then off to Vlad on the next slide.
On March 9th, we vaccinated almost 200 migrant agricultural workers. It was a great opportunity to enroll clients into our program and book appointments as needed. We're also working on getting everyone vaccinated. Next slide. We're excited to be able to offer the COVID vaccine to our agricultural workers. We carve out specific farm worker vaccination dates from our busy nurses' schedule and worked diligently to get everyone who requested the vaccine schedule. We coordinate with growers, office staff, and directly with the patient to best meet everyone's needs. We also offer weekend appointments and make special accommodations as needed. We ensure that staff is bilingual, depending on the population being served each day. Agricultural, again, PPE is distributed to agricultural workers for their personal use and also for their families. Continue precautions and discuss after their vaccine is administered. Next slide. What is the new norm? For us, it means a lot of changes, thinking outside the box and adapting to the patient's need. Our enrollments are now being done over the phone. It can be difficult to contact some clients based on work's expectations, but when we're successful, you can complete all enrollments and screening forms efficiently. We have distributed thousands of personal protective equipment items to the agricultural workers and owners. We have continued to do this with no contact. We have had the pleasure of working with Mass League to obtain these items to help care for our patients. Delivery of hand sanitizer, gloves, and many different masks have been well received. We're also able to supply thermometers and disinfectant wipes. We help with not only the payment of prescribed medication, but also help to set up no-cost delivery. This helps to protect everyone from unneeded exposure and is also convenient. Next slide.
When we transitioned to virtual appointments, we quickly identified the need for smartphones with video ability and data cards. We secured grant funding for the purchase of these items and have been distributing them as needed. Diabetes management can be difficult during a pandemic. We did our best to support our patients in their healthcare journey. We are able to supply diabetic kits, and Judy will get more into the details of our diabetic population in an upcoming slide.
Thank you, Casey and Vlad. So there were some challenges in caring for our patients due to the pandemic, obviously, and the shelter-in-place ruling forced us to significantly limit the number of in-person visits that were conducted, and this led way to a broader spectrum use of telehealth. Some of the issues were that point-of-care testing was not available during telehealth, and additionally, not everyone had access to that cell phone and data to benefit from the telehealth visits. At Generation, 60% of our ag worker encounters in 2020 were telehealth. And while there was concern about the lack of point-of-care testing and access to telehealth services, the no-show rate across our agency decreased significantly from 10% to 10% from a previous 18% no-show rate. And then, of course, here's where the village approach is revisited. It took everyone working together to assure the best possible care for our patient population. How did telehealth affect our diabetes management? Getting lab results was a real challenge. I'm sure you're all aware. Patients were not consistently refilling medications. Community resources were limited due to the shelter-in-place order. And ultimately, diet was limited and people were not getting as much exercise as previously. When you add to that the increased stress due to social isolation, causing an increase in the hormone cortisol being released into the body, put all of these things together and these elevate glucose levels. Using our practice analytics, we were able to risk stratify and create targeted reports to identify migrant and seasonal workers that have uncontrolled diabetes with an A1C greater than 9. These reports provided to our CHWs enabled them to contact the patients telephonically to remind them that an A1C was needed. By scheduling a brief in-office visit for a point of care test or having the provider forward an order to the lab allowed us to get those patients up to date with their lab results. Additionally, when they were speaking with these patients, the CHWs and care coordinators were able to identify those social determinants of health that were causing barriers to care, and they were able to, again, assist with those community resources. In 2019, our agency had a baseline of 36% of uncontrolled diabetic patients in our Farmworker health program. Following the first quarter of 2019, utilizing care coordinators and community health workers, we had brought that down to 31.58% of uncontrolled diabetics in that Farmworker population. Concurrently, we were working with our Community Health Center Association and engaged in a community clinical integration project. And through risk stratification, we found that there was a significant disparity that existed for patients with diabetes who identified as white Hispanic between the ages of 18 and 39. We kept that initial cohort at just 34 individuals so that we had a small working group to begin our project. The baseline data did show that 33% of this group had an A1C greater than 9 in comparison to only 26.5% of our overall agency population. We did a root cause analysis regarding diabetes, and that's one of the basic tools used in a Six Sigma program. And the principal idea behind the tool is the fact that for every effect, there has to be a cause. And therefore, the quality of the problem can be viewed as an effect for which there may be one or multiple causes. In doing this, what we determined was that social factors and lack of diabetes education were likely the root causes for a higher rate of uncontrolled diabetes amongst this cohort. To address the disparity, we engaged the subpopulation of patients with a care coordinator to identify social determinants and ask about the barriers to care. The care coordinators were able to address the barriers and also connect the patient with their primary care provider to do a thorough review of their diabetes status and determine a comprehensive treatment plan to improve their outcomes. After a period of only 3 months, 12 of the 14 patients in that original cohort who had completed the social determinants of health had improved their diabetes control to below 9. It's really important also that we note through care coordination, there were another 7 who were gaining control of their diabetes who had an A1C between 9 and 10, who originally were between 11 and 13. In this slide, it shows we had expanded upon the integration project by utilizing our community health workers and care coordinators to apply these same strategies to our entire migrant and seasonal agricultural worker population. And quarter over quarter, we improved our uncontrolled diabetes in the Farmworker program. We went from the 36% baseline for 2019 to an end year Q4 result of 15.18% of uncontrolled diabetics with an A1C less than 9.
Judy?
Yeah.
Oh, sorry. I was just going to say we just have about three more minutes to go if we want to leave any room for Q&A. And just
okay.
Thank you so much, Judy.
Okay. So I apologize if I'm talking too fast. It's just this is the more important information or the better information I wanted to present. So additionally, we did implement RNs to provide education, teleretinopathy, foot exams, et cetera, to help us improve. Going back to some of the things that Casey talked about, we provided the track phones for patients who didn't have access to data. We also had these diabetic kits, and here you can see what some of the items were in there. So they were pretty plentiful. Another interesting factor was the debit card for COVID relief. That was through a not-profit agency in our state, where we were able to give debit cards to people who did not qualify for the COVID relief funds, and mainly undocumented. And through this, we were able to provide 304 individuals with these debit cards to help them through the pandemic and loss of wages. And so if you look at this slide and you see, if you begin with the patient, you give them access to quality healthcare, you connect them to supports and services and help them navigate the healthcare system. If we assist them in accessing community resources, and we do this on a continuum, then what we have is a patient-centered focus with evidence-based care that's accessible, sustainable, and measurable. And in this slide, it shows that we know this. This is evidence-based because despite the pandemic, we were able to not only maintain our diabetes control for 2020, but we ended the year with an improved outcome over 2019 with only 12.5% of our migrant and seasonal worker population being uncontrolled. So over a 2-year period, we dropped from 36% of uncontrolled diabetics all the way down to 12.5%. Thank you.
Thank you so much, Judy. Elizabeth Gandara Castillo said all great information. Thank you. And I just wanted to see if there were any other questions from our lovely attendees. Thank you so much again for joining us for the session. And I know it's 11 o'clock. I don't see any other questions currently in the chat. Maria Bustamante said thank you to both Casey and Judy. Amy Shepard from River Valley said this is amazing work, improving uncontrolled diabetes.
Thank you, Amy.
Thank you so much again, and everyone, for joining us for the Village Approach Patient-Centric Care Amidst a Pandemic. And thank you so much again to our amazing presenters, Judy and Casey, and to everyone for attending. We hope you have a great rest of your day.
And thank you, Nectar and Sai.
Yeah, thanks, Vlad and Glory, for your part too. I really appreciate it. Great job, everybody.
Thank you so much.